Good day. On behalf of Echosens North America, I welcome you to our webinar entitled FAST, an Advancement in the Identification of Fibrotic NASH, featuring Dr. Stephen Harrison. I am Jerry Mayberry, the host of today's webinar. Before we begin the presentation, I would like to review a few administrative details. To sustain audio quality during the webinar, all participants are muted. Questions can be easily submitted for Dr. Harrison to respond to at any time by merely typing into the questions pane on your computer screen. We will aggregate all questions and read them to Dr. Harrison during the question and answer period. We apologize in advance if we're not able to get to all entered questions. Today's webinar is funded by Echosens North America, the inventors, manufacturers, and distributors of the FibroScan technology and the FAST score. This presentation includes information on the uses of the FibroScan technology from the published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan device is FDA cleared as an aid to the diagnosis and monitoring of patients with liver disease as a part of the overall assessment of liver health. It is not intended for the treatment of any specific liver disease or condition. Now I would like to introduce Dr. Harrison of Pinnacle Clinical Research in San Antonio, Texas. Many of you already know Dr. Harrison as he's a long-standing thought leader and investigator in the field of fatty liver disease for both diagnostics and treatments. For those of you who may not know Dr. Harrison, he completed his internal medicine residency and gastroenterology fellowship at Brooke Army Hospital Center in San Antonio. Subsequently, he completed an advanced liver disease fellowship at St. Louis University. He's the past associate editor of hepatology, and he's currently the associate editor of alimentary pharmacology and therapeutics. And without further ado, I would like to turn the presentation over to Dr. Harrison. Dr. Harrison.
Hey, thanks, Jerry. It's great you guys are on today and to discuss kind of where we are with non-invasive testing for non-alcoholic fatty liver, and particularly as it's related to FibroScan. So I hope you've had your coffee like I've had this morning. I'm all jacked up and ready to talk about this. It's an exciting time. It's a pivotal year. If you're listening today, you probably know it's a pivotal year in the setting of NASH. We have our first potential new drug to treat fibrosis in NASH patients. We have another phase 3 readout that should come any day. 2 phase 3 trials are currently enrolling. Multiple myriad of phase 2 trials are enrolling. Lots of readouts anticipated at EASL and AASLD this year. And then on the non-invasive testing front, just a wealth of knowledge and data that's coming out. I was at the FDA on Monday. Lots of interest in non-invasive testing. So I think this is going to be a pivotal year for lots of things, not just drug development, but for disease awareness and identifying patients at risk as well. And that's my task today, is to jump into where we are with identifying patients at risk non-invasively. Without further ado, I'm just going to move through. This slide highlights who I am. I am the medical director here at Pinnacle Research, company I founded about 4 years ago after retiring from the Army, and I'm still on staff also at Oxford University. So just a couple comments about FibroScan indications for use that you see here. There are several different FibroScans, the 502 Touch, 530 Compact, the 430 Mini, and basically you can read the data there. The shear wave speed and stiffness in CAP may be used as an aid to diagnose and monitor adult patients with liver disease as part of an overall assessment of the liver, and also can be used in pediatrics. So our agenda today is to drive through 4 main aims: the burden of fatty liver, just to kind of give you an update on where we are there, and then jump immediately into therapeutic options and development, just kind of take you through a 30,000-foot view of where we are in drug development for this disease, highlight some challenges that we have, and then really talk about diagnostic options, and then end with what the FAST score is, how to use it, that sort of thing. Okay, so just some background as we talk about fatty liver. We've gained a little bit of clarity over the past couple of years in trying to wrap our brains around how common is fatty liver. There's been several meta-analyses done that have analyzed this, and what we know is that roughly about a third of patients over the age of 50 have fatty liver disease. It varies from region to region and country to country in how you measure and assess fatty liver, but we know from studies, including one we did in San Antonio using MRI-PDFF, which is the gold standard for fat detection, that about 1/3 of patients over 50 have that. It's certainly variable depending on the population. We know that Hispanics are enriched for fatty liver, and African Americans are protected from at least a more progressive or aggressive form of fatty liver NASH. We know that diabetes and obesity are both inextricably linked to the prevalence of and etiology of this disease. We know that only a minority will ever progress beyond fatty liver. In fact, it's 20 to 25% of people with fatty liver will progress, and we don't know exactly who those rapid progressors are in the cohort, although we do know that diabetes is linked to more rapid progression. I'm going to go to the next slide here. Looking at predictors of long-term outcomes, this study was published in Hepatology in 2017. It was a systematic search from multiple different databases. 5 adult fatty liver studies were combined, and mortality data was assessed. Ultimately, about 1,500 patients were analyzed. And really just looking at the graph on the right, you can see that at stage 2, liver-related mortality really begins to ratchet up. Now, this was more recently verified by a study in gastroenterology that just came out. Rod Taylor is the first author, and that's a meta-analysis of about 13 trials, has about 3 times as many patients in it, and about 500 deaths. So it's a little bit more robust, but basically it concludes with the same results that liver-related mortality is linked to fibrosis in the setting of NASH. So having that as a background, you can begin to see why when we look at defining the efficacy of drugs and who we study in the setting of NAFLD, our phase 3 trials in fatty liver are mainly focused on F2 and 3 patients, and the reason for that is that's where we begin to see the increase in liver-related mortality. Now, there are F4 studies underway, although they are still more rare than the milder forms of liver disease, but there are some underway, and many more are set to start in 2020. So what about this future burden of NASH? And it's hard to really, again, wrap our brains around the future burden. We know that the prevalence of diabetes and obesity continue to rise, and it's felt that both the incidence and prevalence of fatty liver will continue to rise. And here's just a snapshot of where we were in 2015 and where we're predicted to be in 2030. And if you look at cases of stage 3 fibrosis due to NASH and then cases of cirrhosis, 2 million, 1.3 million about 5 years ago, predicted to climb to about 4.5 million and 3 million. And what goes along with that is increasing incidence of decompensated disease, liver cancer, and liver-related death. So it's no question we have a problem on our hands. And this is just another way of drilling down on that, looking at the future burden of NASH in Europe, the Middle East, US, and Asia. And in the blue bar graph is kind of where we were in 2016, and in the red is where we're predicted to go. So you can see that in every situation, in every country that's being analyzed, in every region, that there's an increase that is predicted. So just moving over to therapeutic options, and I think based on this rising awareness of the severity of this major epidemic, there's been kind of a shift in the pharmaceutical industry towards developing drugs to combat this, as we begin to realize that fatty liver is not just an innocent bystander of a diabetic or obese patient, but that in the right setting, fatty liver disease can actually be the major driver of morbidity and mortality. And having said that, we also know that fatty liver is also a driver of CV outcomes, of cardiovascular outcomes, MACE events. So I think, trying to target liver disease in the setting of diabetes and obesity is attractive, because not only theoretically can we prevent liver-related events, we can also potentially impact CV outcomes. And so there's really 5 buckets of drug development that are underway. There's those modulating insulin resistance and lipid metabolism, those modulating lipotoxicity and oxidative stress, and then you see the rest here: inflammation, dysregulated immune cell function, and then apoptosis, necrosis, and fibrosis and collagen turnover. The vast majority of these agents are really focused on the first 2 buckets, and the reason for that is because we have learned that, at least with our current mechanisms of action, the higher up in the pathways that we target modulation of this disease, then we think the better effects we are going to have downstream. An example of that would be, we know that free fatty acid flux into the liver is very toxic, and the liver wants to do a couple things with that fatty acid as quickly as it can. It either wants to esterify it into triglycerides, which is an inert fat storage vehicle, or it wants to burn it in the form of beta oxidation, or it wants to repackage it and ship it out of the liver as quickly as it can in the form of VLDL, or very low density lipoprotein. So if we're able to modulate free fatty acids coming into the liver, we're able to increase the burn rate of fatty acids, then we feel like we'll modulate all the downstream effects of that, meaning we improve oxidative stress, we have effects on mitochondrial health, endoplasmic reticulum stress, autophagy, and ultimately activation of stellate cells. Whereas if you act more distally in that, potentially you're only targeting one small pathway that could be overcome by redundant pathways higher upstream. So that's just an overview of kind of where we are currently. Now, I mentioned earlier I was at the FDA on Monday, and currently still there are 2 approvable endpoints, and these are surrogate endpoints, meaning that typically the FDA approves claims, not drugs. They're going after really targeting how a patient feels, functions, or survives. And so in the setting of fatty liver drug development, it takes a long time for patients to progress from mild disease to cirrhosis to liver-related or all-cause mortality, liver-related morbidity, mortality. So to overcome that and to encourage drug development, there is this unique opportunity to do what's called Subpart H approval. And that means that if you hit a surrogate endpoint, which is a surrogate for a long-term outcome, that you will be conditionally approved to sell your drug, and you still have to go on and show that the drug impacts how a patient feels, functions, or survives, but you're able to market and sell your drug in the intervening period. So the 2 Subpart H approvable endpoints currently are liver biopsy based, NASH resolution, or fibrosis improvement. And there's some caveats around that you see underneath. If you look at NASH resolution, it has to be resolution of steatohepatitis on a liver biopsy, and there can't be any worsening of liver fibrosis. Alternatively, you could improve liver fibrosis by at least 1 stage, and there can't be any worsening of steatohepatitis. So with that as the context, we're going to move forward. And I mentioned this already, that endpoints for outcomes measures in NASH really can be broken down into a couple different points, and they can be clinical, metabolic, inflammatory, or fibrotic. But ultimately, these all may be challenging to measure because the disease progresses slowly. If we're using liver biopsy as that target, there are limitations to liver biopsy that we all know. But ultimately, if we break these down into clinical, we can look at progression to cirrhosis. So, if you're designing a phase 3 trial and you achieve Subpart H approval because you improve fibrosis, then ultimately you need to show that you reduce the progression to cirrhosis. So that involves, usually a third liver biopsy. There's a liver biopsy to get into the study. There's one at a 12-month or 18-month time point to show you achieved some improvement in fibrosis to get you that Subpart H approvable endpoint, and then another biopsy maybe 3-4 years down the road looking at did the patients progress to cirrhosis. Obviously, all-cause mortality, liver-related mortality are pretty obvious to measure. And then you can look at reductions in liver fat content, improvement in insulin resistance, impact on lipids, etc. But again, surrogate endpoints can be used for conditional approval. The only ones that currently are approved by the FDA are the two that I mentioned on the previous slide. So how do we measure these surrogate endpoints? Well, if we're looking at clinical data, we can do an imaging study looking at fat and fibrosis, whether that's vibration-controlled transient elastography or FibroScan, MR methods, MRI PDFF, MR elastography, and wet biomarkers. And some of the new biomarkers that are coming into vogue would be ProC3, which is a marker of fibrogenesis, and ELF, which is a compilation of 3 different biomarkers put together in a panel that a lot of work has been generated showing that actually is efficacious in determining who might progress to cirrhosis and who might progress to a long-term negative outcome. There's Child-Turcotte-Pugh scores, MELD scores, hepatic venous pressure gradients as well. And ultimately, this all comes down to a group of wet biomarkers and a group of imaging biomarkers that can be helpful in looking at these surrogate endpoints. And you can see here in this next slide drugs that are kind of targeting and where they're targeting. Some drugs that, as you know, that are in the middle of phase 3 or late phase 2 or even have read out would be the FXR agonist class, some of the PPARs, the PPAR alpha delta, which is elafibranor, then thyroid hormone receptor beta agonist have progressed into phase 3 as well. So this whole notion of enrolling clinical trials is an important one. Why? Well, because A, there's multitudes of drugs in development right now, and B, we're trying to go after that 20 to 25% of people that have NASH in the setting of fatty liver. So there's an issue with enrolling clinical trials quickly. There's also a problem with screen fail rates in NASH clinical trials. In fact, the screen fail rate in most phase 3s is around 60 to 70%, with the vast majority of those being due to liver biopsy, meaning the liver biopsy doesn't show enough disease to qualify them for the trial. And again, most of our phase 3s are taking NASH patients with F2 and F3 fibrosis. So how can we get better at this? How can we develop tools that can help screen a large population of patients and really only pick out those that are at greatest risk? Because at the end of the day, we don't want to be doing unnecessary liver biopsies or putting people through unnecessary tests that don't need them or that don't have advanced liver disease due to fatty liver. So I think that's really where we're headed in the next part of this talk is trying to identify patients at risk. And who is that at-risk population? Well, for the purposes of the rest of this discussion, that's going to be a NASH patient with F2 or greater fibrosis. So I wanted to highlight what I mentioned earlier, which was screen fail rates for clinical trials in NASH are very high. And this slide really highlights that, I think, and brings it home that 55 to 60% of patients, even in our phase 2 trials, are screen failing if we have to identify patients with a NAFLD activity score of at least 4 and F2 and F3 fibrosis. And again, in the red here, you see failed biopsy qualification is more than 50%. And you see on the bottom box that the reason they're screen failing is either they have no NASH, no fibrosis, or an inadequate sample, or maybe there's NASH but no fibrosis, or the other way around, there's fibrosis and no NASH, or in the setting of a trial that doesn't include cirrhotics, well, we're diagnosing cirrhosis. So this is a big area that I think we can improve on. The other one I highlighted in red is failed image qualification. And this gets to two big things. So in phase 2 trials, where we're really kind of looking at proof of concept data, we're trying to develop our non-invasive testing strategy, we often use MRI. Well, MRI is expensive. And so we want to optimize our probability of success when we send patients to MRI. And so is there a way we can do that? Is there a way we can drive down screen fail rates on MRI by pre-selecting patients to have a high probability of passing MRI? Now, when I say passing MRI, usually that's in the setting of an MRI PDFF, which is liver fat content. And most of our studies require an MRI PDFF of 8% or 10% liver fat content. Now, just to set that stage for you, a liver fat content of greater than 5% meets the definition of fatty liver. So is there a tool out there that we can use that would increase the probability of hitting MRI PDFFs of 8 to 10%? And the answer is yes, and we'll talk about that as well. So, the real question here is, getting back to a slide I showed earlier, is if you have a large pool of fatty liver patients, how do we find the at-risk patient, or the patient that has active fibrotic NASH? And then the next question is, how much fibrosis is there? So drilling down on this a little bit more, if we want to identify higher risk NASH patients, we could start with this graph. And here we have an at-risk NASH patient defined as a NASH patient with a NAFLD activity score of 4 or more. And I'll explain that here in the next slide or two, with F2 or greater fibrosis. So if we look at the spectrum of patients out there that we see, in green we have a healthy population. We have a large population of fatty liver, and then we have those that have cirrhosis. So if we drill down just on the NAFLD population, we can identify those that have no NASH and those that have NASH. Drilling down on that even further, we can get at that high-risk NASH patient, which is the NAS greater than or equal to 4 with F2 or greater fibrosis. And ideally, when we define an NAS of 4 or greater, we're really looking at steatosis, ballooning, and inflammation. Because at the end of the day, to make the diagnosis of NASH, you need all 3 of those components. So there's some pragmatic first steps that you can do in suspected NAFLD patients. Well, the first one is risk identification. Who is that patient phenotypically that's at greatest risk of this disease, of fatty liver that is, that has the risk of NASH with F2 or greater fibrosis? Well, what we know is that the older you get, the higher the likelihood of having NASH, and really over the age of 50 puts you in that risk category. In fact, if you look at all our clinical trials that enroll NASH patients, the mean age of a NASH patient is somewhere around 50 to 55 years of age. Metabolic syndrome, we know the more components of metabolic syndrome you have, the higher the prevalence of fatty liver. And we know there's some high-risk ethnic groups, with Hispanics kind of being at the top of that risk group. And however, Caucasians and Asians are right behind them in risk category, with African Americans being the least likely to have NASH. And then we can look at simple lab tests, ALT, AST, and those can be very predictive as well. And just my caveat I always say there is fatty liver is an ALT predominant disease. It's much higher, usually on the order of 1.5 times that of the AST. So a good example would be in a NASH patient you might see in clinical practice. ALT would be 60, AST without any fibrosis would usually be somewhere in the 30s, maybe 40 range. Now, where we begin to worry about fibrosis is when the AST begins to rise to the level of the ALT. So in the example I used where the ALT was 60, if the AST was 60, that would be a red flag to me, that this patient is very likely to have advanced fibrosis. So it can be helpful in that setting. And then imaging investigation, right? These people have fatty liver, so how do we get at fatty liver? Well, the most basic way to do it is a right upper quadrant ultrasound. That has a high sensitivity for fat. The problem is it doesn't quantify fat very well. So this is where we can use something like transient elastography, and a part of FibroScan is this thing called a CAP, or controlled attenuation parameter, that gives me a pretty good idea of fat in the liver as well as how much fat. And we'll talk about that in the following slide. So you have kind of 3 different gates. You have phenotypically, what does the patient look like, some basic lab tests, and then some basic imaging tests that could be done. So I just want to highlight a couple of these. This is some work that I did. Now it's getting pretty old, about 12 years ago, published this in Gut, where I looked at a large population of fatty liver patients, and I broke them down into fatty liver alone, NASH with no fibrosis, NASH with stage 1 to 2 disease, and then advanced disease with F3, F4 fibrosis. And I hone in on the laboratory data, particularly ALT and AST. And this illustrates the point I made just a moment ago, that ALT is predominant over AST in the setting of fatty liver alone and mild liver disease. But as you progress, as you go from left to right across the screen, you begin to see the ALT drop slightly and the AST continually climb, such that by the time you're at F3, F4, usually the ALT and AST are about the same number, and by the time you're cirrhotic, the AST is often slightly higher than the ALT. Now, the important caveat to note here is that AST alone lacks sufficient positive predictive value to adequately predict NASH and fibrosis. And you'll see that's a recurrent theme as I go through the next set of data. Now, on this slide, there are simple online fibrosis calculators. If you're listening to this presentation, you probably are pretty savvy at this. There's the NAFLD fibrosis score, the FIB4, the APRI. I highlight here the FIB4 and the APRI. There's online calculators that will provide you the outputs from this, and you can use these readily in your clinical practice. And I'm an advocate for them in the right setting. The issue is that both of those tests have high negative predictive values, but their positive predictive values, just like AST, are relatively low. So I want to give you this in a little bit more granularity on this slide. This is cutoff scores for measurements of advanced fibrosis using FIB4 and the NAFLD fibrosis score. And on the left is high sensitivity, absence of advanced disease. On the right is high specificity, presence of advanced fibrosis. And you can see that there's a large indeterminate group in the middle that's about a third of the patients. And again, both of these tests are very good at their negative predictive value, but they lack sufficient positive predictive value to be used alone to predict NASH and fibrosis, unless you're dealing with a population that just has a whole bunch of advanced disease. Maybe you're in a liver transplant clinic or something like that. But certainly if you're in a primary care office, a primary GI office, usually our prevalence of advanced disease is relatively low, and so we have a lower positive predictive value. Now, there's been a shift lately of looking at sequential non-invasive testing to reduce the number of patients in this indeterminate zone. And I'll highlight this here for you. If you decide to use one simple non-invasive test, maybe it's the NAFLD fibrosis score or the FIB4, this is what you get. You get about a third of patients are able to say they don't have disease, about a third probably have disease, and then about a third have indeterminate. If you combine one test with another non-invasive test, now you basically shrink that indeterminate indeterminate zone. And so the sequential use of non-invasive tests maintains sensitivity and specificity while enabling the classification of a larger proportion of patients by minimizing the indeterminate zone. So how do we get at this a little bit better? So I published this a couple of years ago now. It's really kind of a pyramid, if you will, that highlights the highest risk patients. And I mentioned this on a couple of slides before, but now I want to provide a little more granularity on what I mean. We talked about middle age being at risk for this disease. What is that? That's over the age of 50. We talked about comorbidities, metabolic syndrome. Really, the diabetes population is the low-hanging fruit for this, where 75% of them have fat, but almost 40% of them will have NASH on a liver biopsy. And when you begin to add hypertension and obesity to diabetes, you drive up that prevalence even more. When we drill down on imaging modalities like FibroScan, at about 8.5 kilopascal, we begin to define the patient that has NASH with fibrosis with more accuracy and precision. AST greater than 40. I mentioned that as you go from a normal AST and you rise the level of AST, that's really linked to fibrosis progression. And then I've already highlighted NAFLD fibrosis score in FIB4, and then we know that Hispanics are enriched for this, as well as that AST-ALT ratio. In other words, as the number of AST and ALT begin to equal each other, that gets you a ratio of 1 or more, and that puts you in the high-risk category. It doesn't mean that people in the intermediate zone can't qualify for disease that puts them in a study, and that would be age over 40, well-controlled diabetes, FibroScans greater than 7, AST greater than 20, but the likelihood of them qualifying is less. So I try to hone in on that high-risk, low-hanging fruit group first as the ones that I think are the highest likelihood of qualifying for a study or having advanced disease. Now, I want to maybe put some clarity around FibroScan here. A lot of you have FibroScan or use it, and I think this slide illustrates the points I want to make. So what we can say is that FibroScan kilopascal is most reliable in ruling out advanced fibrosis. The negative predictive value is better than the positive predictive value. And we know that fibrosis really is unlikely if the KPA is less than 6. Doesn't mean you can't have disease. It's just much less likely to be there when the KPA is less than 6. So I don't associate, and I want to say this a couple times, I don't associate a KPA number with a fibrosis stage. And I think those that do really are maybe stating more than what's actually happening. What we know is that as you move from a lower FibroScan to a higher FibroScan, the likelihood of having more advanced fibrosis is there. That is true. But we're not granular enough to know exactly what stage they may be. So what I like to say is FibroScan values less than 6, I don't worry so much about the patient having fibrosis. If it's greater than 8.5, I say that there's possibility for mild to moderate scarring. If the FibroScan is somewhere between 10 and 13, that's a higher likelihood of moderate scarring. And if it's greater than 13, that's a higher likelihood of more severe scarring. We know from a recent publication from the data put out by the NASH CRN that if your KPA is less than 13.1, the negative predictive value for cirrhosis is 99%. So we can say with confidence that if the FibroScan is less than 13.1, that they don't have cirrhosis. But the flip side is not true. In fact, the positive predictive value for cirrhosis with a KPA greater than 13.1 is only 39%. So what that tells me is that when you have an abnormal FibroScan, and for me, I define that in the purposes of a clinical trial at greater than 8.5, that tells me we need to do more workup, that we need to take that patient and put them through more testing, whether that's MRIs, more wet biomarkers, maybe even a liver biopsy. I tell my patients that, look, there may be an issue here. We need to do more investigation. And I don't tell them if their KPA is 17 that they have cirrhosis. I just say, look, let's do some more workup. You're at risk. You have fatty liver. You have these other clinical risk factors. But let's get more data together before we really put you in a bucket of staging your liver disease. So I wanted to focus on CAP as well in this discussion because we need CAP to help us define fatty liver. And we know here that at CAP thresholds of greater than 280, that's really an accurate number for giving us the best sensitivity and specificity for finding patients with fatty liver. And we know that at CAPs of greater than 280, that it has a good correlation with MRI-PDFF of greater than 5%. Clinically, we know that at CAPs greater than 300, we can predict the probability of having a liver fat content on MRI greater than 10%, more than 80% of the time. Let me say that another way. If our CAP score is greater than 300, we can feel confident that that patient has a decent amount of fat in their liver. And how good is our confidence? It's about 80%. Okay, are there other non-invasive tests out there? Sure there are. There's a couple that are in development now. One is called NIS4. It combines 4 different wet biomarkers. It's being developed now by a lab here in the U.S. And collaboration with GenFit. And it's very promising. The AUC for this test at predicting the same group of patients, NASH with an NAS of greater than 4 with F2 to 3 fibrosis, or greater than 2 fibrosis, pardon me, is about 80%, or an ROC of 0.8 or greater. And FibroSpect is also being developed, and you can see ADAPT and ProC3. It's not quite as far along, but that's a test that is still being investigated and has promise. ProC3 by itself is being looked at as a fibrosis biomarker. And then now we have FAST, and this publication has recently come out in the Lancet Gastroenterology and Hepatology. I encourage you to pull the manuscript down and read it, and we're going to jump into that and tell you a little bit about that in the next few minutes. So if we were to pre-screen and put an algorithm together to tell us about how to find these people with NASH and F2 or greater fibrosis, again, you would look at the risk factors, their clinical risk factors. You could calculate, and this is just one example, you could calculate the FIB4, the NAFLD fibrosis score. And if they're at lower risk, then you would exclude them, meaning that the negative predictive value is very high. If they were in that higher risk category, and you see the cutoffs here, you would do a FibroScan. And based on this one publication by Castera et al., published in 2019, actually several publications, you could use a FibroScan cutoff of greater than 8 using the mProbe, or greater than 7.2, and consider screening them for a clinical trial. In my own practice, I highlight here to the right, I like to go with a KPA of 8.5 or greater. To me, that gives me a little bit better specificity. Having said that, you can use sequential tests. And we know that sequential tests lead to a smaller indeterminate zone, and we've shown that already. And I highlight this paper in hepatology by Quentin, a good friend of mine at UK Newcastle, that looked at data from the Stellar trials, which were focused on F3 and F4 fibrosis, and showing that sequential tests led to a lower indeterminate rate. So now I want to shift gears and in the last few minutes talk about the FAST score. This is a clinical decision support tool. It's a calculator. It's a tool for clinicians that will calculate the probability that a patient with a suspicion for fatty liver might have advanced fibrotic disease or disease with F2 or greater fibrosis. And the FAST score calculator takes into account 2 different measures on FibroScan, the KPA and the CAP, as well as a clinical variable called the AST. So the goal of FAST was to help you in clinical decision making, to improve the quality of referrals for clinical trials, and to provide a cost-effective approach to assessment and point-of-care testing, and ultimately to provide a simple tool from which clinicians could use to find these patients. So when we, again, need to set the stage by defining the at-risk NASH population, this is those to the right of the spectrum, the NASH patients with an NAS of 4 with greater than F2 disease. And so how do we define an NAS? So NAFLD activity score is based on steatosis, it's based on inflammation, and it's based on ballooning. And there's also, separate from the NAS score, the fibrosis component. And you can see that steatosis has 4 different options, 0 to 3. Inflammation has 4, 0 to 3, and ballooning 0 to 2. And here, when we're looking at the definition of NASH, we need to have at least 1 point in each of those 3 categories. And when we define the range of NAFLD activity score, it could be 0 to 8. An example of 8 would be a steatosis score of 3, inflammation score of 3, and this is lobular inflammation, by the way, and then a ballooning score of 2. So the FAST score formula, you're not going to memorize this. I put it here just to show you that this is really statistically derived through logistic regression analysis. Now, just highlighting some of the data that came out of the paper. When we look at the derivation cohort, this study was originally done in 350 patients with suspected fatty liver that attended liver clinics in England, and they were prospectively enrolled in this derivation cohort. You can see the baseline here, and ultimately the population that had NASH with an NAS of 4 or more with F2 or greater fibrosis was approximately 50% of that. Then I think really importantly to highlight, there was multiple external validations of the FAST score from French bariatric surgery cohorts, a cohort here in San Antonio, all the way to Asia, Malaysia, Turkey, and then at the end you see the pooled external patient cohorts of over 1,000 patients, where about a quarter of them met the definition of NASH with an NAS of 4 with F2 or greater fibrosis. And you can see that the ROC, or the accuracy of the model, ranged from 0.8 to as high as 0.95, and so this is a very good test for defining this population. If you wanted to compare the performance of FAST to FIB-4 and NAFLD fibrosis score, this was done. You can see that here in the bar graphs, with the FAST score being in orange, the FIB-4 in red, and the NAFLD fibrosis score in brown. And again, just looking at the ROCs and comparatively across the studies that were looked at with external validation, you can see that with the exception of Turkey here, that the FAST score performed better than the others. And then when we look at performances using a dual cutoff approach, let's say we want to take the FAST score and we want to apply it very similarly to the way the FIB-4 and the NAFLD fibrosis score was done, where you have a high sensitivity group, you have which excludes disease, you have a high specificity group which highlights the group at risk, and then of course, is there an indeterminate group in the middle? What you can see is that at cutoffs here of 0.35, you have a high sensitivity greater than 90%, greater than equal to 90%. And if you have a cutoff of 0.67, you rule in disease with a high specificity of greater than or equal to 90%. And you can look at the different cohorts of people to see where you fall relative to those 2 cut points. And it's relatively the same across the board. So we'll take that, and I want to apply that now maybe a little bit clearer. And this is looking at sensitivity, specificity, positive and negative predictive value in graph C. And in graph D from the paper, and this was taken straight from the paper, looking at the screen fail rate, the missed case rate, and the proportion of patients identified. And I think this will help us apply those cut points in a real-life situation. So here, on the left, you see sensitivity, and it's in the red, and specificity in blue, and then you have positive and negative predictive value. And where the sensitivity and specificity are optimized, we call that Uden's index, and that you can see where the red and the blue lines cross. Over on the right in graph D, this is interesting because to me, my goal in clinical trials is to minimize the screen fail rate. And that's in the green bar, the green line coming down. So as you increase your FAST score, we basically improve our screen fail rate. We drop our screen fail rate. Now, if we go too far to the right, we're going to raise our misclassification rate. So there is a sweet spot in which you don't want to go past. But ultimately, we can use that higher FAST score, that 0.67, to define our population at greatest risk for disease and decrease our screen fail rate. And that's really ultimately what this graph shows us. So again, this is that interpretation of the FAST score, kind of repeating what I showed on the previous slide. And I'm going to give you some examples. So here, if you have ultimately 100% and at the bottom 0%, in the middle 50%, you can begin to see if that's the cutoff you want. If you want to define your screen fail rate at 50%, then you can see what you need to have from your FAST score cutoffs. Alternatively, if you want to have and this is, let me go back and say, your missed case rate would be 0%, and then you would have a very high, a very low misclassification rate and a screen fail rate of 50%. Alternatively, if you went too far to the right, we would have 100% missed case rate, but ultimately you would see a very low screen fail rate. So it's trying to find that sweet spot in the middle where we optimize the benefit. And you can begin to see that here, where we drop the screen fail rate by shifting our FAST score to the right. And it happens again the further we shift it to the right. So I wanted to apply this in my patient population here in San Antonio, and we did that in 510 patients, 240 of them with a liver biopsy, 270 of them without. And again, when we looked at the FAST score and applied it to our population, on the vertical axis you see the FAST score, on the horizontal axis you see whether or not they met the criteria of NASH with an NAS of 4 or more with F2 or greater fibrosis. And those that did, on the right in the brown box plot, you see that their mean FAST score was greater than 0.5. Alternatively, if they did not meet that, they had a very low FAST score. So this is kind of a real-world evaluation of using that tool. So again, looking at a real-world cohort using diagnostic thresholds, on the top are patients with a liver biopsy, and you can see the rule-out cutoff for sensitivity greater than or equal to 90% is 0.21. And if we wanted to use the high specificity cutoff, it would be 0.3. And you see very good negative predictive values. The positive predictive value not as ideal. But when we shift over here and we look at FAST relative to FibroScan or AST, the ROC is much better. So if, again, taking an imaging biomarker, combining it with a wet biomarker, gives us a better accuracy of identifying patients that we want to with this disease. Now, you can put it all together. There's an app. It's called My FibroScan. It's readily available. It's online now. And this will calculate the risk score for you. You just put in the CAP score, you put in the AST, and you put in the KPA, and it gives you your FAST score. And you can tweak this to what you feel like would be important for you in your clinical practice. So here, if you had a FAST score of 0.74, that's derived from a CAP of 345, a KPA of 10.9, and AST of 67. This is a patient for me in my clinical practice I would absolutely refer to a clinical trial. And if I didn't have a clinical trial, this is, and I'm in my clinic, this is one that I would move forward to do further testing to identify more specifically the stage of disease. So with that, I will wrap it up and open this to questions. Thank you for taking part in today's call.
Thank you, Dr. Harrison, for that informative presentation. I would like to remind all participants that you can enter additional questions at any time in the questions pane of your computer, and we'll continue to monitor for your questions, and we'll ask as many as time allows. Now to support the questions, I'd like to introduce my colleague, Dennis Mesh of the Echosens Clinical Specialist team. Dennis will be reading the questions to Dr. Harrison for his response. Dennis, please proceed with the first question.
Dr. Harrison, the first question is, what FAST score probability level will you likely use in your drug trials to help you determine who to refer for biopsy?
Well, that's a good question. One of the things that we look at, again, is what's going to optimize our yield, what's going to minimize our screen fail rate. And just, again, going back to one of the slides, slide 40, where we had that, for me, around 0.6, somewhere between 0.6, 0.65 would be that optimal threshold for me to move forward. Certainly the example I used at the end, 0.74, I think, is definitely one. But and then the alternative is I probably wouldn't refer them at all if it's less than 0.3, maybe 0.35. So there's still an indeterminate zone. I think that's where we use our clinical judgment. We apply some of the phenotypic factors like diabetes, obesity, hypertension, maybe family history of disease, that sort of thing, to help guide us out of that indeterminate zone. But hopefully that answered your question.
Okay, thank you. Next question. Is it feasible to use the FAST score to screen patients with NASH risk factors? If so, what FAST score probability would you use in this context?
Well, it is, and I don't really want to put a FAST score cutoff on that because I really think it depends on the population that you're examining. Hispanics are going to be a little bit different than Caucasians, Asians, Samoans, African Americans. Diabetes is different than non-diabetics and that sort of thing. So I think you have to look at it in the context of your patient. Phenotypically, what do they have? Again, you always need to ask your patients about family history. If they're telling me that their grandmother died of fatty liver disease, didn't drink alcohol, their brother or sister has the disease, that puts them at an increased risk score. And so even if the FAST score was low, I might still move them forward in that situation. So I think it just kind of depends.
Okay, thank you. Question 3. At what disease stage does a patient typically become symptomatic?
Yeah, unfortunately, you've got to be cirrhotic to become symptomatic and some modicum of decompensation. Having said that, about 10 to 20% of our patients will have intermittent right upper quadrant to epigastric pain that's related to swelling of Glissen's capsule and infiltration of fat in the liver. Patients often can complain of fatigue, but that's a very nonspecific symptom. And about a third of patients will be hypothyroid and on some type of thyroid replacement therapy. Having said that, though, the vast majority of people we see are completely asymptomatic. And I'll take that one step further. In our prevalence study that we recently completed, where patients presented for routine colon cancer screening and were very healthy otherwise, had no symptoms. In fact, they were adamant that their livers were completely healthy. We found that the prevalence of NASH was 15%. This was an average age of 55. And of those patients that had NASH, a third of them had F2 and F3 disease. Again, highlighting the fact that all these people were asymptomatic and had no complaints, despite having a third of them having moderate to advanced liver disease.
Okay, thank you. Next question. Can a FibroScan test differentiate cirrhosis NASH versus cirrhosis secondary to HCV?
No. So
okay,
let me clarify
yes.
that just a bit more. So, you can use typically in Hep C, unless you're genotype 3, we don't see fat in the liver. So you could look at CAP, and if the CAP score was less than 280, but the KPA was very high, and there were other clinical markers that would go along with cirrhosis, maybe a low platelet count, maybe a low albumin, maybe a high INR. then that might be informative. The problem with that is, in the setting of fatty liver, as you progress to cirrhosis, you begin to lose the fat in your liver, such that in many patients, in fact, a third of patients that have cirrhosis due to NASH, there's no fat left in the liver. We call that quote-unquote cryptogenic cirrhosis. If we transplant those people, the vast majority of them will have fatty liver in 6 months following their liver transplant. I still stand by my answer. No, I don't think FibroScan can distinguish Hep C cirrhosis from NAFLD cirrhosis.
Okay, thank you. Next, is the relationship of ALT and AST you explained present solely in NASH, or is it also present in viral hepatitis?
Well, that is present in any liver disease outside the setting of alcoholic liver disease. In alcohol, we know the AST supersedes the ALT by almost an exact 2-to-1 ratio. But other liver disease, whether it's Hep C, autoimmune, Hep B, typically that's the case. I guess one other caveat is drug-induced liver injury. Sometimes you see some abnormalities that aren't consistent with that. But certainly with viral hepatitis, autoimmune hepatitis, iron overload, Wilson disease, alpha-1 antitrypsin, fatty liver, everything but alcohol, you're going to see that ratio be okay.
Okay, thank you. Next question. Is FibroScan and the FAST score useful in pediatric NASH?
Hasn't been tested yet, to my knowledge. Jerry might have that answer, but I don't think it's been tested in kiddos.
Yes, that's absolutely correct.
Okay, moving on. Next question. Should we switch to the FAST score instead of FibroScan alone in pre-screening?
So that's in my practice, even before the FAST score came out, I shifted about 2 years ago to using AST plus FibroScan. And my cutoff was 20 for AST and an 8.5 on the KPA. Because what we basically were able to do early on in clinical trial development, was take our screen fail rate on liver biopsy from 60% down to the mid-30s by using that approach. So, I think it's something to consider, using the FAST score and the app that's available. I think at a minimum I would combine a clinical biomarker with FibroScan. For me, I like AST. We just are getting, the FAST app. We're just getting this up and running. So it's something to see if FAST will be the way to go. But it's based on AST anyway. So my supposition is that I will begin to use FAST more frequently as we move forward in a pre-screening algorithm.
Okay, thank you. Next question. In a patient with a FAST score above 0.50, what other features should we consider in pre-screening?
Yeah, I mean, we talked about that already. The keys there are there other factors at the top of that pyramid that I showed you? Are they over 50? Do they have diabetes? Are they Hispanic? Are they, postmenopausal, female? That sort of thing that puts them in that high-risk category. So that's basically what you're asking me is there a third variable that would be helpful, right? Because by default, FAST includes AST and a FibroScan, and now you're wanting to add a third or fourth variable, and that would be just your phenotypic data that you have available. So yeah, I mean, the more you have, the better. But I would say in the setting of a FAST score greater than 0.5, you're really getting up there. And if all you wanted was another variable to tip you over, then diabetes is a great one that would do that.
Okay, well, thank you. Last question. Does FAST have a role in ASH?
I don't know. It hasn't been studied in ASH. My guess would be the way it's currently defined, the algorithm that's currently used, it would not, because this is an AST predominant disease, and ASH is really a wastebasket term that includes alcoholic steatohepatitis with acute alcoholic liver injury, and ASTs can be prohibitively high in that situation. So A, it hadn't been studied in that population, and B, I think it would be, your algorithm would be a little bit different.
Okay, thank you.
Very good. Thank you, Dr. Harrison, and thank you to Dennis Mash for helping with reading the questions. We've now consumed all the time allotted for today's webinar. On behalf of Echosens North America, I'd like to thank everyone for participating in today's event, and particularly to Dr. Harrison for his perspectives on the new FAST score. All attendees will receive a follow-up message with a link to a recording of this webinar. Please feel free to share that link with your colleagues who weren't able to join today's event. And with that, I say good day and thank you to all.